everyone, this is your mentor Dr. Nikhita from StudyMEDIC, and today we'll be discussing about the module Postpartum for MRCOG Part 2. So the important topics in this module will be postpartum hemorrhage, mental health, and perineal tears. So starting off with the postpartum hemorrhage. We all know that PPH is loss of 500 ml or more of blood from the genital tract, and if it happens within 74 hours of the birth of the baby, we call it primary PPH. And if there's any abnormal or excessive bleeding from the birth canal between 24 hours and 12 weeks postnatally, we call it secondary PPH. So PPH is of two types, minor and major, and major is further divided into moderate and severe. In minor PPH, we quantify the blood loss as 500 to 1000 ml. In major, it is more than 1000 ml. In moderate, it's quantified as between 1001 and 2000 ml. And in severe PPH, we say when the blood loss is more than 2000 ml. So we all know that the causes of PPH can be because of the 4 T's: tone, trauma, tissue, and thrombin. And out of these 4, the most common is because of hypotonicity. So now we will understand why PPH happens in various scenarios. So in factors like multiple pregnancy, PPH is because of the hypotonicity. Previous PPH is also because of hypotonicity. In cases of preeclampsia, it is because of thrombin factor. In macrosomia, failure to progress and prolonged third stage is again because of hypotonicity. Retained placenta and placenta accreta, it's because of the tissue factor. And episiotomy, perineal laceration is because of the trauma factor. And in general anesthesia, it's because of hypotonicity again. So let's understand how we can reduce the blood loss of delivery. So it is now given in the guidelines that uterine massage is not a way to use prophylactically to reduce the bleeding. We must not use this as a measure to reduce the loss at delivery. Routine use of prophylactic uterotonics to manage third stage of labor is a very good way of reducing blood loss at delivery. And routinely we give injections syntocinon 10 international units intramuscular within 1 minute of the birth of the baby after a normal delivery, and injections syntocinon 5 international units slow IV is given within 1 minute of the baby's birth during cesarean section. So for women without any risk factors for PPH, delivering vaginally, as I told you, 10 units IM injection. This is a fact. And now after cesarean section, IV oxytocin 5 international units is given. That is also true. Now, for women without any risk factors for PPH delivering vaginally, more than 10 international units of oxytocin by intramuscular injection is of use. No, there is no proven benefit of giving more doses. And ergometrin oxytocin may be used in the absence of hypertension. Yes, it can be used. It's called as symptometrin. For women with increased risk of hemorrhage, combination of preventive measures is superior to syntocinon alone to prevent PPH. Yes, this is also a true statement. Use of intravenous tranexamic acid in addition to oxytocin at cesarean will reduce the blood loss in women. Yes, this is also proven. And moving on to management of third stage of labor, we have 2 types, expectant and active. In expectant management, the signs of placental separations are awaited and then the placenta is delivered spontaneously. Whereas in active, we use uterotonics, we do early clamping of the umbilical cord and controlled cord traction, and this will expedite the delivery of the placenta to reduce the blood loss post-delivery. Early cord clamping is proved by NICE guidelines that leads to lower birth weight and lower blood volume, and hence it is now practice that umbilical cord should not be clamped earlier than 1 minute from delivery of the baby if there are no concerns over cord integrity or the baby's well-being. So ergometrin and oxytocin has similar efficacy of like oxytocin, but 5-fold increased rate of increasing the blood pressure, nausea and vomiting. It is a true statement. And prostaglandin F2 alpha, that's nothing but prostaglandin, misoprostol can be used in place of oxytocin. No, it is false. We cannot use or replace oxytocin in active management of third stage of labor with any other uterotonics. And use of carbetocin resulted in a statistically significant reduction in the need for further uterotonics compared with oxytocin alone for those undergoing a cesarean, but not for vaginal delivery. It is true. So for post-delivery by cesarean section, we can use carbetocin as well. There is statistically significant differences between carbetocin and oxytocin in preventing PPH. This is a false statement. Visual estimation of peripartum blood loss is inaccurate and often underestimating. That is true. We often estimate the blood loss visually and we underestimate it. So it should not be relied upon. Hence, we should rather look into the clinical signs and symptoms in the assessment of PPH. So when the blood loss is around 1000 to 1500 ml, we observe tachycardia, tachypnea, and a slight recordable fall in systolic blood pressure. Now, when the PPH is in excess of 1.5 liters, the systolic blood pressure will be below 80, associated with worsening tachycardia, tachypnea, and altered mental state. Moving on to how do we manage the PPH. For minor PPH, that is blood loss between 500 and 1000 ml without any clinical shock, first of all, we have to gain intravenous access through a 14 gauge cannula and urgent venipuncture to draw 20 ml of blood and sending for Rupen screen, full count and coagulation screen, including fibrinogen levels. And we also monitor pulse, respiratory rate and blood pressure every 15 minutes, and we have to commence warmed crystalloid infusion. In case of major PPH where blood loss is greater than 1000 ml and continuing to bleed or in clinical shock, first we have to do the basic resuscitation by following the ABC rule, where we assess for the airway, breathing and then evaluate the circulation. Remember to position the patient flat and remember to keep the woman warm. Transfuse blood as soon as possible and if clinically required. Until blood is available, we can infuse up to 3.5 liters of warmed clear fluids. Okay, so that includes initial 2 liters of warmed isotonic crystalloid and followed by colloid. But remember, hydroxyethyl starch should not be used. Special blood filters should not be used as they slow the infusions. So as we discussed, up to 2 liters of crystalloid, 1.5 liters of colloid can be given until the blood arrives. And until the blood is arriving, if group specific blood is unavailable, you can give O negative blood and K negative red cell units and switch to a group specific red as soon as feasible. FFPs can be administered if PT or APTT are prolonged and hemorrhage is ongoing. You can administer 12 to 15 ml per kg of FFP, and if hemorrhage continues after 4 units of red blood cells and hemostatic tests are unavailable, you can administer 4 units of FFP directly. Platelets, 1 pool of platelets if hemorrhage is ongoing and the platelet count is less than 75,000, and cryoprecipitate, 2 pools of it is given if hemorrhage is ongoing and fibrinogen less than 2 grams. So here these are the numbers to be remembered for the therapeutic goals after the management of massive blood loss after a PPH. So HP should be aimed at maintaining over 8 grams, platelets more than 50,000, PT less than 1.5 times the normal, again APTT less than 1.5 times the normal, and fibrinogen should be maintained more than 2 grams per liter. So routine use of recombinant factor 7A is now recommended in the management of major PPH. This statement is false. Most common cause of PPH primary is uterine atony. Again, it is a true statement. So until initial management of PPH, you can do myometrial stimulation by doing a massage. In medical management, we palpate the uterine fundus and rub it to stimulate the contractions. Ensure that the bladder is empty. Oxytocin 5 international units by slow IV injection. Ergometrin 0.5 mg by slow IV or IM injection. Oxytocin infusion 40 international units in 500 ml isotonic crystalloids at 125 ml per hour unless fluid restriction is necessary, and carboprast about 0.25 mg by IM repeated at intervals of not less than 15 minutes to a maximum of 8 doses, and used in caution in women with asthma. Misoprostol 800 micrograms sublingually. Moving on to the surgical interventions. If pharmac measures fail to control the hemorrhage, surgical intervention should be initiated. First line surgical intervention is the use of intrauterine balloon tamponade. Conservative surgical interventions may be attempted as second line depending on the clinical circumstances. So it's recommended that a laminated diagram of brace suture technique is always present in the operating theatre, and always remember to resort to hysterectomy sooner than later, especially in cases of placenta accreta and uterine rupture. And whenever you decide to do a hysterectomy, that is cesarean hysterectomy, always seek a second opinion from an experienced clinician, and they should also be involved in the decision for the cesarean hysterectomy. Now moving on to B-Lynch or Heyman sutures, they are nothing but compression sutures which are associated with low complication rates. A higher risk of uterine ischemia appeared to be caused when the procedure was combined with vessel ligation, and no negative impact on fertility has been reported. So in stepwise uterine devascularization, we first ligate the single uterine artery followed by bilateral uterine arteries, and then lower uterine arteries, single ovarian artery, and bilateral ovarian arteries. So this is the first line conservative surgical treatment to control the PPH. So when internal iliac artery ligation is to be considered, always remember to involve a vascular surgeon who is skilled in doing this technique. And uterine devascularization techniques, including the internal iliac ligation, does not adversely affect the future fertility, and even the brace suture does not affect the future fertility. So moving on to management of secondary PPH. In secondary PPH, always rule out infection, and it's important, that's why, to send for a high vaginal and endocervical swabs, and appropriate use of antimicrobial therapy should be initiated when endometritis is suspected. A pelvic ultrasound may help to exclude the presence of retained products of conception, although the diagnosis is unreliable. Surgical evacuation should be undertaken or supervised by an experienced clinician, because often there are chances of perforation of uterus in such a state. So this is another important topic in postpartum module, that is urinary retention in postpartum period. So whenever a catheter is removed or a woman is delivered, first we have to ask these VESI questions. Did you pass a good volume of urine? Did your bladder feel empty at the end after micturition? Do you have a sensation that you still want to pass urine? Was your stream normal, and was there any incontinence? Now suppose we are supposed to encourage the woman to void within 4 hours of catheter removal, and a further 2 hours can be given, totaling 6 hours. Now suppose the woman has not voided, we have to put an in and out catheter and look for residual assessment. If it is less than 150 ml, you should look for the causes for oliguria. If it is between 150 and 250 ml, we can attempt at second void at 6 hours post the catheter removal. If it is between 250 to 700 ml, we have to insert a catheter and retry trial without catheter in 24 hours. And if it's more than 700 ml, patient should go home with a catheter for at least 2 weeks. Now suppose she says that she has voided, you will ask her the VESI questions. In this VESI questions, if any of the questions she answers yes, then we have to put an in and out catheter to assess the residual volume. If it is less than 250, proceed second void at 6 hours post catheter removal. 250 to 700, insert catheter and retry trial without catheter in 24 hours. And if it is more than 700, patient to go home with the catheter for 2 weeks at least. Now suppose she says she does not have any symptoms suggestive of VESI, then you have to put an in and out catheter, do a residual assessment, and if it is more than 700, patient needs to go with catheter for more than 2 weeks. And 150 to 700, you can retry trial without catheter in 24 hours. Less than 150 means successful trial without catheter in the postpartum period. Okay. Moving on to the mental health. So depression identification questions is something that we need to ask every woman, and this you'll understand better in the part 3, where we ask these 2 questions in every case history. So basically the 2 questions are: during the past month, have you often been bothered by feeling down, depressed or hopeless? And during the past month, have you often been bothered by having little interest or pleasure in doing things? Now, to check for anxiety, we use the Generalized Anxiety Disorder Scale, that is GAD-2 scale. Over the last 2 weeks, how often have you been bothered by feeling nervous, anxious, or on the edge? And over the last 2 weeks, how often have you been bothered by not being able to stop or control worry? Now, for questions about anxiety, an answer of not at all scores 0, several days scores 1, more than half of the day scores 2, and nearly every day scores 3. And remember, for women in childbearing age, use of contraception and any plans for a pregnancy should be noted down, and how pregnancy and childbirth might affect a mental health problem, including the risk of relapse, should be told to the patient, and how a mental health problem and its treatment might affect a woman, the fetus and the baby should be told, and how a mental health problem and its treatment might affect the parenting must also be explained. Remember not to offer valproate for acute or long-term treatment of a mental health issue in women or girls of childbearing potential, unless other options are ineffective or not tolerated and the pregnancy prevention program is in place. So definitely valproate should not be used. So whenever a psychotropic medication is started in pregnancy and the postnatal period, consider seeking advice, preferably from a specialist in a perinatal mental health, and choose the drug with the lowest risk profile and the lowest effective dose, and use a single drug rather than 2 or more drugs, and take into account the dosages that needs to be adjusted pre-pregnancy. So here is a question. A 32-year-old woman with severe mental disorder is 6 weeks pregnant. She has stopped all her medications by herself soon after she found out that she was pregnant. And now she's asking about the prognosis. So you tell her that there is no need to restart any medication throughout the pregnancy, or you tell her that there will be no need for any psychological intervention. Tell her that there is a need for increased monitoring and support throughout pregnancy. There is no need for increased monitoring and support, and none of the above. So the answer to this is C. Definitely there's an increased need for monitoring and support. So when a woman with severe mental illness decides to stop medications, you have to tell her about the possibility of restarting the medication or switching to some other form of medication and having a psychological intervention, and ensure that she will be getting increased level of monitoring and support throughout the pregnancy. So here is another question. A 30-year-old woman with anxiety disorder is on medication for the past 6 years. She's now 5 weeks pregnant and stopped all medications after pregnancy is confirmed. Now about her prognosis, you tell her that A, no need for any medications during pregnancy, or chances to switch to safer medicines if required, or no need for any psychological intervention, no need for increased monitoring, and none of the above. So definitely you will tell her that there may be chances to switch to a safer medicine if required during pregnancy. That is option B. So here is another question. 28-year-old woman is on psychotropic medications with teratogenic risks since 5 years and has irregular cycles. She later found that she was 9 weeks pregnant and she was taking medication through this period. Now what is the prognosis? So no chance of any fetal damage. You can't promise her this, definitely. Stopping or switching the medication after pregnancy is confirmed, may not remove the risk of fetal malformations. No psychotropic intervention required, no need for specialist review, and none of the above. So definitely it is answer B. Stopping or switching the medication after pregnancy is confirmed, may not remove the risk of fetal malformations. In severe mental illness, definitely refer to a secondary mental health service for assessment and treatment for all women who have or are suspected to have severe mental illness, and they have a history of severe mental illness during pregnancy or postnatal period or any other time in the past. So if a woman has any past or present severe mental illness, or there is a family history of severe perinatal mental illness in the first degree relative, be alert for possible symptoms of postpartum psychosis in the first 2 weeks after childbirth, And if a woman has sudden onset of symptoms suggesting postpartum psychosis, refer her to a secondary mental health service within 4 hours of referral. So this is a 2 weeks referral period where a woman with a known or suspected mental health problem is referred in pregnancy or the postnatal period. You will have to treat her within 2 weeks of referral and provide psychological intervention within 1 month of initial assessment. So moving on to postpartum psychosis, severe mental illness with a dramatic onset shortly after childbirth. It may be mania, severe depression, or a mixed picture with features of both high and low mood. Evidence of psychosis with delusions and hallucinations is common, marked by confusion and perplexity. Women with bipolar disorder have at least 1 in 4 risk of suffering severe recurrence following delivery, and bipolar women with personal or family history of postpartum psychosis are at particularly high risk with greater than 1 in 2 deliveries affected by postpartum psychosis. So genetic factors, obstetric factors, changes in medication, hormonal changes, and seed proliferation are the risk factors. Incidence in 1 in 1,000 deliveries. In psychosis, you have to ask for risk factors in the antenatal period and look if it is having sudden onset and rapid deterioration, and within 2 weeks of delivery, more than 50% of the symptom onset will be between day 1 and day 3 of delivery. So wide fluctuation in the symptoms and severe mood swings will be observed. Delusions and hallucinations will be present, and both elation and depression symptoms will be there, and apparent confusion and bewilderment will be there. So you have to differentially diagnose between baby blues, postpartum depression, and postpartum psychosis. So in baby blues, it affects 30 to 80% of the births and causes transient emotional lability during the first postpartum period. But remember here, the patient may feel sadness, insomnia, tearfulness, irritability, anxiety, but the care of the baby is never impaired. Okay, so they do not feel suicidal. It is self-limiting, but assessment should ensure that the woman is not and does not become more severely depressed. So postpartum psychosis is definitely a psychiatric emergency and admission is required. Early recognition and aggressive treatment is a must. Complications include neglect of the baby, attempt to suicide or infanticide, and non-puerperal recurrence. So moving on to the last topic, that is perineal tears. So perineal tears are often classified into 4 degrees. The first degree, there is injury to the perineal skin and vaginal epithelium only. In second degree, there is involvement of the perineal skin as well as the muscles of the perineum, which includes the superficial and deep transverse perineum, the fibers of the pubococcygeus and bulbocavernosus, and second degree lacerations do not extend into the anal sphincter muscles. So often the episiotomy that we give is a second degree because it involves the perineal skin as well as the muscles. Now third degree tear is the one which involves the perineal skin, the muscles, and also the anal sphincters. So they are classified as 3A, B, and C. In 3A, less than 50% of the external anal sphincter is torn. In 3B, more than 50% of the external anal sphincter is torn. And in 3C, both external and internal anal sphincters are torn. Fourth degree perineal tear, they involve a tear in the perineal skin, muscles, both external and internal sphincter, and also the anal epithelium. So it is often called as complete perineal tear. So grade 3 and grade 4 perineal tears are together known as obstetric anal sphincter injuries or the OASCs. Now in rectal buttonhole tears, it does not included in this classification. And in case of doubt during classification of third degree tears, whether you're confused as it is 3A, B, or C, it is always better to classify it to a higher degree than to a lower degree. So this is a picture where in the first degree perineal tear, you see only the tear in the epithelium, whereas in second degree, both the epithelium and the muscle is torn, but whereas the anal sphincter is completely intact. In the third degree, we see that there is a tear in the skin, muscle, as well as the sphincter. And in the 4th degree, there is a complete tear and connection between the vagina and the anus. So overall incidence is 2.9%, primipara is 6.1%, and multipara is 1.7%. So moving on to how we repair these tears. The anorectal mucosa, we use 3-0 Vicryl and never PDS, remember this, and we use the continuous or the interrupted technique. In internal anal sphincter, we use 2-0 Vicryl or 3-0 PDS, and interrupted and mattress end-to-end sutures only. And external anal sphincter, again we use 2-0 Vicryl or 3-0 PDS, and in complete tear we do a end-to-end kind of a overlap repair, and in partial tear we do a end-to-end but never overlap. Okay, remember the knots must be buried under the superficial perineal muscles. This reduces the risk of knot or suture migration to the skin, and skin is always closed by subcuticular using Vicryl rapide. So post-repair care and follow-up, always debrief the patient, duty of candor should be followed, document and incident reporting. Antibiotic, make sure to include metronidazole. Laxative, lactulose for about 10 days is prescribed. Remember not to prescribe any debulking agents. Follow-up, physiotherapy has to be given for the patient. Pelvic floor muscle has to be strengthened. So review after 6 to 12 weeks by clinician with interest in OASI, and refer to colorectal surgeon and MDT. Final evaluation will be done after 12 months. So the prognosis, 60 to 80% will have complete resolution within 1 year, and 20 to 40% will have persistent symptoms. So this was about the important topics in the postpartum module. I hope this lecture has helped you, and we encourage you to join StudyMEDIC for more such learning and for success in MRCOG exams. Thank you so much for watching this video.